So
Yeah,
good evening and welcome all. So my today's presentation is newer update in the management of first line biliary tract cancer. So we all know the statistics that almost 30,000 cases has been reported in India, and there has been an increase in trend for incidence of biliary tract in both males and females over the years, although the females are the leading in the incidence of the biliary tract cancer. So what are this current management in the advanced biliary tract cancer? So we have three baskets in it. The first is the chemotherapy with the options of GemCis, FOLFOX, FOLFIRI. The second basket is the targetable mutations I'll discuss in the further slides. And the third basket we have is the latest immunotherapy options, that is durvalumab, pembrolizumab, and now CAR T cell therapy and vaccines. So we all know about ABC2 study, like how GemCis has been established as a standard first-line chemotherapy for advanced biliary tract cancer. It is still remains the standard of choice with no newer therapies improving the outcome. That was before the pre-immunotherapy area. So I don't want to waste much time on it. So we know the comparison of GemCis versus GemOxy. The overall response rate, the EFS and OS was almost similar. It depends on the patient profile. If the patient have diabetes like neuropathy, then it favors the use of GC. While the lower incidence of hematological toxicities and the potential ease of administration, it favors in the favor of gemcitabine and oxaliplatin. So I think the response wise both are same, but on the patient profile, it depends which we need to choose. So this was the pre-immunotherapy NCCN guidelines. We all are aware of those immunotherapy, the chemotherapy options. And now this is the latest NCCN 2024 post-immunotherapy era guidelines. We can clearly see addition of durvalumab and the pembrolizumab. And in the metastatic disease, we have various targetable mutations and respective therapeutic drug. I'll discuss in detail in the further slides. So, which is like the first immunotherapy in the first line advanced biliary tract cancer. We all know about Topaz 1 trial. It is a phase 3 randomized double-blind placebo-controlled study of durvalumab. So basically, the design is like it's a phase 3 study of locally advanced metastatic biliary tract cancer with recurrence greater than 6 months after surgery or adjuvant therapy. And it's basically compared durvalumab plus chemo versus placebo plus chemo. And the durvalumab was giving 4 weekly and the GemCis were also giving 4 weekly until progressive disease for up to 8 cycles. So this was the patient profile. Most of the patients are in locally advanced and metastatic settings. And the ongoing treatment patients in Durva plus GemCis are 63 in the current data. And we can clearly see that how the difference in the median on survival between Durva plus GemCis versus placebo plus GemCis, which shows a sustained 2 year sustained and durable overall survival benefit. So the difference of median OS at 12 months was 54 versus 47 months. At 18 months, it was 34 versus 24. And at 24 months, it was 23 versus 11.5%. And with the significant p-value, it shows that once it's starting showing response to Durva plus GemCis, I think it will be continued for a longer time. But this is the patient profiling. I think the maximum benefit was seen in locally advanced status. And we look at this PFS benefit, then 7.2 versus 5.7 months with a significant p-value of 0.001 as being a superb results for Durva plus GemCis, and the 12-month PFS percentage range was 16% versus 6%. So I think it's a very good response of Durva plus Gem. Similarly, we have seen like the PFS benefit was seen favoring Imfinzi plus GEMS across all the subgroups, and the maximum benefit was seen in the locally advanced biliary tract cancer as per the forest plot. So this showed that a significant superior overall response rate within 1 in 4 patients which respond beyond 1 year. That is 24.6% versus 18%. So if a patient start responding to Durva plus GEMS, I think the response becomes sustained and more durable for another 2 years. Yeah, this we have discussed. So yeah, this is I want to say that remaining in the response for greater than 12 months, then 26% versus 15% is the duration of response for greater than 12 months in Durva plus GemCis. So that's what I said. Patient who responded continued to respond better and beyond 2 years. And among responders, there was a clear and sustained separation of curves beginning approximately 15 months after randomization. And similarly, among participants with the best objective response of stable disease, there was a sustained separation between the curves at approximately 6 months. So even at the stable disease point of view, the response of Durva plus GemCis is better than placebo plus GemCis. So no, if we talk about the side effects, I think Only the immune therapy related side effects was add-on in Durva plus Gemcis. None of the side effects leads to the discontinuation of the therapy, and most of the side effects are in the range of grade 1 and grade 2. If we talk about the immunotherapy related side effects, they were there, but only few of them are like less than 2.5% patient experiences greater than equal to grade 3 immunotherapy associated side effect. So on the basis of side effects also, I think Durva plus Gems is a well tolerable regimen, and it does not lead to the added toxicity. So, and also this is a slide which shows that the Durva plus Gemcis was associated with the OS benefit irrespective of the immune therapy associated side effect. So suppose patient have hypothyroidism, fatigue, any of the side effect, then it does not lead to the difference in the overall survival because the discontinuation rate was less and less than 2.5% has grade 3 effects. So this is the latest developed in 2023. It was approved in the NCCN guidelines. So the conclusion about Durva plus Gem says it looks statistically significant, meaningfully progressed OSN as compared to placebo plus Gem says, and it is effective across the all molecular landscape of BTC and patients with targetable genomic alteration. It did not lead to additional toxicity, and Imfinzi 1500 mg in combination with chemotherapy is approved in adult patients with locally advanced and metastatic biliary tract cancer. So Topaz was the first global phase 3 trial data to give positive results with immunotherapy in combination with immunotherapy. I think we have already seen the NCC in 2024 slide indicating as a category 1 recommendation for locally advanced and metastatic biliary tract cancer. The second latest edited immunotherapy trial was Pembro plus Gemcis. I'll quickly say on it. The eligibility criteria remains the same, histologically confirmed cholangio and gallbladder cancer. And the comparison was Pembro 200 mg with Gemcis versus Gemcis. And we can see that at the end of it was carried up to 36 months, the study. And the median OS was 12.7 versus 10.9 months, and the 12-month overall survival percentage was 52 and 24-month overall survival percentage was 25. So I think it's almost similar to the Topaz one. So pembrolizumab versus placebo, 6.5 versus 5.61 is the PFS benefit, which leads to combination now FDA approved with locally advanced unresectable or metastatic biliary tract cancer. We can see the separation of the curves. This is just a slide comparing Topaz 1 and Keynote 966 trial. And just on the basis of region, this is more in Asian. Intrahepatic were included more in Keynote. MSI high was more in Keynote. And this was just about HBV infection rate. So this was all about the two major immunotherapy trials, the Topaz 1 and the Keynote 966, and both leads to the major approval of the combination of immunotherapy with chemotherapy in locally advanced or metastatic biliary tract cancer. Now, what about the other genomic landscape? So it is a very large landscape, and we see that mostly in the cholangiocarcinoma. So FGFR2 fusions and IDH1 mutations occur almost exclusively in intrahepatic cholangiocarcinoma, whereas HER2 amplification in KRAS occur more commonly in perihilar and distal. So the therapeutic landscape has been transformed in cholangiocarcinoma with identification of actionable alteration in 40 to 50% of intrahepatic cholangiocarcinoma and 15 to 20% of perihilar and distal. So I think intrahepatic cholangiocarcinoma has the maximum of genomic alterations, and luckily and fortunately we have a therapeutic targets available for it. So this is the just a quick diagram to show the incidence of various targetable mutations in which NTRK fusion incidence is less than 1%, MSI 1 to 3, TMB high is less than 5, BRAF 1 to 5, RET fusion is very less than 1. So FGFR2 fusion or rearrangement is between 9 to 15% intrahepatic, and IDH1 in 10 to 20 in intrahepatic, and HER2 amplification is 5 to 20 and 15 to 30% in gallbladder cancer. So we all know that for cholangiocarcinoma, the two approved drugs for FGFR is pemigatinib and futibatinib. Both are FGFR receptor 1 to 4 kinase inhibitor. They have some difference in their mechanism. We can clearly see that the duration of response, the PFS, was 6.9 months in pemigatinib arm, but in futibatinib it was 9 months. The overall survival was almost same. So the indication was treatable, unresectable, locally advanced or metastatic cholangiocarcinoma with an FGFR2 fusion or other rearrangement. So the most important side effect has been hyperphosphatemia. and all patients should have a baseline eye examination before the therapy initiation, because there is some dry eye, keratitis and conjunctivitis, retinal pigment epithelial detachment, and regular muscle cramps and myalgia. So hyperphosphatemia and regular eye examination before starting this drug is essential. These are just the comparison of the side effects. Now, if we see that the IDH1 mutations are mostly common in intrahepatic cholangiocarcinoma, we can clearly see that the blue line of IDH1 is very common in intrahepatic, whereas KRAS mutation is more common in extrahepatic, the orange line. Similarly goes for TP53. So KRAS and TP53 are more in extrahepatic. Rest of the mutations like IDH1 is most common in intrahepatic cholangiocarcinoma. So CLAR-DHY study comparison the drug against the IDH1 mutation is ivosidenib and versus placebo. So we can see that the 12-month response rate was 22%. We can clearly see the separation of the graph, and it is approved by FDA for treating with locally advanced metastatic cholangiocarcinoma with susceptible IDH1 mutation who have been previously treated. So I think it is mostly indicated in the second line option. So the safety regular side effect is nausea, diarrhea, fatigue, abdominal pain, cough. Most common is nausea and diarrhea and fatigue. So the trans2 plus per2 for HER2 positive biliary tract cancer, and also the median OS benefit we can see is of 10.9 months. The grade 3, grade 4 adverse effects are 46%. Most frequently was raised liver parameters. So this is the diagram showing the benefit in HER2 positive biliary tract cancer, the waterfall plot, that how effectively if we combine the trans2 plus per2 against the HER2 positive biliary tract cancer. This is another study of tucatinib plus trastuzumab for previously treated HER2 positive, and the results were better as compared to the placebo. The most common treatment-related adverse effect with dual HER2 inhibition is diarrhea, and similarly as discussed before, that is the raised liver parameters, anemia, fatigue, and alkaline phosphatase. So also we know that trastuzumab deruxtecan has been approved in NCCN guidelines for advanced HER2 expressive biliary tract cancer, and we have two important trials. One is the HERB trial and one is Destiny Pan Tumor Auto trial, and both of them has shown that even in the low HER2, like the HERB trial has showed that in low HER2 there has been a PFS benefit as well as the median overall survival benefit. And in Destiny Pan Tumor Auto trial in IHC 2+ status, the PFS and OS benefit was also around 4.6 to 7% in as a median overall survival. The side effects are same: anemia, neutropenia, and interstitial lung disease. So like the classical side effect of trastuzumab deruxtecan, even in the breast cancer, was ILD, and it has been seen consistently in biliary tract cancers also. So next is the BRAF and MEK inhibitors, and we all know how it works together. So dabrafenib, this is a ROAR trial. Dabrafenib plus tremelimumab has been indicated as a second-line treatment with no satisfactory alternative options, with the overall response rate of 47%. So the another important is NTRK inhibitors. This is the pathway which NTRK pathway work leading to tumor cell proliferation. Yeah, the major NTRK inhibitors we know is basically the oncogenic driver in various tumor types, and the two important are entrectinib and sulfatinib. It is indicated in patient with advanced NTRK fusion positive solid tumor. So larotrectinib was evaluated in phase 1, phase 2 trial for patient with advanced NTRK fusion positive solid tumors, and the overall response rate was 79%, with complete response observed in 16%, and median PFS was 28.3 months, and I think the OS is very good of 44 months. So the ARROW trial basically has checked about the pralsetinib, the newer generation oral selective RET inhibitors, and sulfatinib has been tested in Libretto trial, and both of them have showed consistent oral response rate, OS, and PFS benefit. So these are the occasional side effects of neuropathy: congenital insensitivity to pain with anhidrosis, leading to TRK-A inhibition, and TRK-B receptor inhibition leads to hyperphagia, hyperdipsia, dorsal root neuron loss, memory impairment, and TRK-C inhibition leads to proprioception defect and motor neuron afferent loss. So these are one of the side effects. Most of them are grade 1 only. Grade 2 and grade 3 are rare. Thank you so much, sir. Thank you.
So thank you, Dr. Pulkit. So just want to one or two queries from my side.
Sure, sir.
Are you comfortable with this regimes, Durva plus Sysjam, or are you using in clinical practice?
Yes, sir. I have one patient on Durva.
Hmm.
So I'll just a minute, sir. Sir, am I visible, sir?
Yeah, you are visible.
Okay. So, sir, I have one patient of Durva and Gemces. The patient has already received Gemces outside and came to with a stable disease. So the patient was alive for almost 11 months. But after 11 months, the disease start progressing. So I had just have one patient with Durva plus Gemces.